Welcome to Better Sex, where you get the information and inspiration to create and enjoy your best possible sex life. Join your host, sex therapist Jessa Zimmerman, as she brings you expert guests, helpful tips, knowledge, and strategies to improve your intimate relationships. And now, your host, Jessa Zimmerman.
Hello. Welcome back to the Better Sex Podcast. This is Jessa, and I am so happy to be with you today. And I'm so happy you're here with me. Thank you. I know there are, I think at this point, I don't know how many tens of thousands of new podcasts come out every day. I appreciate you tuning in and listening to the show. I'm always looking for things that could be helpful to you, and I know that not every show is going to be relevant, right? There's such a variety of topics. Not everything's going to be of interest or meaningful to you right now. But this is one of the shows that if it isn't affecting you now, unless you're in a lesbian relationship, it could affect you someday. So this might be one to either bookmark or listen to and store away in your back pocket for when you need it, because we're going to be talking about erectile dysfunction. I interviewed today Kelifern Pomeranz, who is a licensed clinical psychologist and another AASECT certified sex therapist. She works in Silicon Valley. She's got a practice focusing on all kinds of sexual concerns and agreed to talk in a lot of detail today about erections. What makes them work? What makes them not work? All of that. What are the treatments? All the various medical causes that you really should be ruling out. Do not just go to the doctor and ask for a pill. Certainly don't just go online and order one. There can be some important things to research and understand about yourself before you go into treatment. So today, all about erections, what to do to make them work as well as possible, and some about what to do if they don't. But that we may cover that more in another episode later. So anyway, that's the show today. I hope you enjoy it. Kelifern, thank you so much for being with me today.
Yeah, thanks so much for having me.
Okay, so today is all about erections, right? And lack thereof. I figure is our conversation. And I did one show around male sexual concerns in general, but not so specific on erectile dysfunction. And I think this is going to be really helpful to those that need it. And maybe it can sit in people's back pocket for those that don't need it yet, right? And maybe they never will, knock on wood. But let's start with just a definition. How is erectile dysfunction defined?
Yeah, so erectile dysfunction is defined as a consistent or recurrent inability to attain or maintain penile erection sufficient for sexual satisfaction. And to expand on this definition, symptoms must occur in at least 75 to 100% of all occasions of sexual activity.
Oh, okay.
And the symptoms also need to persist. I mean, this is if we were to make an official diagnosis.
Right.
Symptoms would persist for at least a period of 6 months, and they would have to cause the individual clinically significant distress. And then there's also a distinction, which I guess I'd like to point out in terms of the diagnosis. So we're looking at whether it's lifelong. And so this is relatively rare. I've actually never seen this in my practice, but that it's always been there. Versus acquired, which means it starts after a period of normal sexual functioning. And then the other thing we're looking at is whether it's generalized, so that it occurs across all situations, stimulation in partners, versus situational. So it's only occurring with certain situations or partners. And this is what I often see in my practice, where a man will say, I have no problem with erections during masturbation, but the minute that I'm in a partnered sexual situation, this is when I start to have a hard time getting it up.
Okay, so it's still erectile dysfunction if they have no problem with masturbation.
Mm-hmm.
Right? Okay.
Exactly.
But it's just situational. Okay, so there's a lot I think I want to pick apart in what you just said, because even though that was so concise, it just seems like there's so much there. But the first question it raises is, what's the difference between this and something like performance anxiety? Or is that just the psychological side of erectile dysfunction?
Yeah, so definitely that I would say that's probably the number one kind of psychological cause of erectile dysfunction. So the two definitely go hand in hand, although performance anxiety also can lead to other sexual dysfunctions, such as premature ejaculation.
Right.
And that's something we commonly see with men who are struggling with erectile dysfunction. I think 30% also struggle with premature ejaculation. So we are looking often at a performance anxiety piece of it. But if a man is having performance anxiety and just has erectile difficulties, like every here and there, like just once in a while, it wouldn't necessarily meet the kind of formal diagnosis of erectile dysfunction.
Okay, right. And performance anxiety not being a technical diagnosis in the DSM, right, where erectile dysfunction is. But I'll have clients or people that inquire about services and sort of they're talking about performance anxiety. And when I suggest a book about erectile dysfunction, they're like, wait, that's not me, But a lot of the treatment, some of the treatment can be similar because it's just psychologically induced. Erectile dysfunction. Okay. So you said at least 6 months. I guess what I want to know is what are some of the reasons something like this would go on less than 6 months and then wouldn't get diagnosed and treated? Like, what kind of situations do people have sort of this transitory experience?
Yeah, that's a good question. We might see that with taking a certain type of medication that would lead to it, and then maybe stopping that medication either because they don't like that side effect or because they don't need the medication anymore. We might be looking at, because there can be such a psychological component to it. We might look at like a flare-up of a depressive episode or, a flare-up of kind of anxiety, or maybe just a period of like poor sleep and nutrition and lack. So we might see kind of some temporary things that are contributing, but that don't kind of persist over time.
Okay. All right. So at least 6 months, and you're saying 75 to 100% of the time in whatever the situation is, at least they would struggle. Right.
And this is just for the formal diagnosis.
Yeah. I'm thinking about my own clients who, well, I guess the question is, it's sort of treated in the same way in terms of in our sex therapy practices, whether it's happening for 30% of the time or 80% of the time. It's just about whether they qualify for the diagnosis.
Yeah, I think what's really important is if someone self-diagnoses as having it, you're right. I think the treatment, it can be a lot of the same. If we're looking at some of the more medical treatments, maybe not so much, but definitely in terms of psychological treatments, we're kind of looking, it doesn't matter if they've had it for a month or 6 months or 2 years.
Okay. All right. So how common is erectile dysfunction? And I guess we're looking at, I don't know if you got different statistics for the formal diagnosis version versus the more, intermittent.
I kind of do. So the statistics are really all over the map in terms of how common it is. I think the one that I've kind of consistently seen is that more than 30 million men in the United States struggle with erectile dysfunction. And then there's estimates that by the year 2025, we're looking at 300 million men worldwide.
Wow.
Yeah. When it comes to kind of statistics and research, really the gold standard continues to be this large and detailed federally funded study that came out of Boston, the Massachusetts Male Aging Study.
Okay.
Data was collected over 17 years from over 1,700 men in Boston, ages 40 to 70. And this study showed that 43% of men in the study had some degree of erectile dysfunction.
Wow. Okay.
You asked whether this kind of like longer, like official diagnosis versus. Yeah. So there's this, I was doing some internet research looking at some kind of newer studies. And there's this study, this British study, 2,000 men in their 30s, and it claimed that over 50% of them suffered from erectile dysfunction.
Wow.
I have some kind of issues with this study just in terms of it was a poll. I wrote them to see if I could actually see what was asked in the poll, and they didn't provide me with that information. So I think this is probably a case more where they probably asked questions like, do you experience difficulties with erections some of the time.
Yeah.
And probably didn't meet like the official diagnosis.
Right, right. But all this said, I mean, it is common to struggle,
Yeah.
right? And we know that age is one factor, but there's an awful lot of, I mean, you talked about mental health and medication and lack of sleep, and there's stress, and certainly there's what stimulation are you getting in relationship dynamics? Like there's so many reasons that people may struggle to get or keep an erection.
Absolutely. Right? And I would say that probably most men experience this at some point in their life.
Yes. Yeah. So I guess I want to ask you, and we didn't talk about this in prepping for the episode, so if you don't have answers for that, that's okay. You can just say that. But I'm wondering, what do people want to medically rule out? If they're having erectile dysfunction, that can be a little bit of a canary in a coal mine, right, around some other medical issues. And so I find in my practice, people may have gone to their GP or maybe even their urologist to just get a prescription for Viagra, but they have not necessarily gotten an appropriate medical workup for the things that could cause this, right? So do you have anything to say about what people should be talking to their doctors about?
Yeah, I mean, I do. I see that that's pretty common too, like going to a primary care and just being handed this. I mean, definitely, and we're looking at many things there in terms of physical causes. So I found this one statistic that I thought was really interesting that said that 70% of the time, erectile dysfunction can be traced to physical conditions. And we're looking at things that either restrict blood flow, hamper nerve functioning, or both. Okay. So in terms of kind of physical stuff that we're looking at, so those things that inhibit blood flow, we're looking at, one of the major ones is diabetes. Okay. And we're also looking at hardened arteries, heart disease, smoking. Vascular disease is the leading cause of erectile dysfunction in men, and it accounts for more than 50 to 70% of the cases. Wow. So this is really common. And then we're also looking at hormonal issues, so like overactive or underactive thyroid, overproduction of the hormone prolactin, and then also the male sex hormone testosterone. Right. And then the final thing, well, not the final thing, there's many things, but this is kind of oversimplifying it, but we're also looking at any neurological issues. So again, diabetes falls into this category. Also, Parkinson's disease, multiple sclerosis, cervical disc disease, spinal cord injuries, and then also long-term alcoholism can cause damage to the peripheral nerves. So we're looking at all of these things, and so that would be required to look at for a formal medical evaluation. Okay, yeah, and I guess on the list was to talk about these medical causes, but it just floors me how few men are getting evaluated for these different things. You're just handed this pill as if it's all psychological, or it's all, I don't even know. And I suppose if somebody's 30, maybe it's less likely that they're suffering from some of these things than if they're 65 or something like that. But still, I would imagine the advice is go get, talk to your doctor about all these various possibilities. Right. And I mean, I think that the pill is kind of the easiest thing to give, because so 70% of men whose erections are because of some kind of organic or biological cause, something like Viagra is actually going to help them get an erection. And then in terms of a psychological cause, if they take something like Viagra, 85% of these men are going to get an erection. So it's just really like quick fix. Like if a primary care gives this to a man, like he's likely going to be satisfied with the outcome of having received that medication. Right. But may not find an underlying problem until later. That would be good. Exactly. Good to figure out. And I think right. And I think that's a really big thing about this, is that oftentimes erectile difficulties are a sign, like you're saying, canary in a coal mine, to like something that's going on, such as like a disease state or process. Yeah. And so failing to look at that, I think, can actually be quite dangerous. Right, right. Okay, so maybe this leads into an overview of physically, medically, how does an erection work? Like what's the science of a hard-on, right? Right. Okay. So I'm going to try to keep this simple and not get too technical on this one, but I am going to delve into it.
Everything you ever wanted to know about a penis, listeners. So.
Absolutely. Yes, I'm excited to share. Okay, so the penis is comprised of these 3 cylinders, and one runs along the bottom of the penis and it encircles the urethra, and it keeps it from pinching shut during an erection, thereby maintaining a viable channel for ejaculation. And then there's these 2 other cylinders, so we call these the corpus cavernosa, that run side by side along the upper part of the penis. And they actually take up most of the space inside the organ. And they consist of this sponge-like tissue that's filled with blood vessels and these tiny chambers. And so erections are this complex process that involves the endocrine, the muscular, the vascular, and neurological systems. And each of these systems in turn are impacted by psychological and emotional factors. And so an erection starts in a man's brain in relationship to something that he sees or hears or tastes or thinks or feels. And it sparks this intense activity in the hypothalamus.
Okay.
And then electrical signals from sexual arousal travel from the brain down to the lower part of the spinal cord. And from there, the messages are dispatched along the network of nerves to the penis.
So even if it starts with stimulation to the penis, so we're starting down there, it's still going to travel up to the brain to be interpreted as a sexual thing and then back down to the system direction. Okay.
Yeah. So from there, the messages are dispatched along this network of nerves to the penis, and the tiny muscles within the walls of the penis arteries are told to relax. And so this opens up those corpora channels to allow more blood flow into the flaccid penis. And so while blood is always flowing in and out of the penis, when you're aroused, blood flows at a rate of 6 to 8 times its normal rate.
Okay.
So the penis becomes engorged, the arteries distend, the small chambers fill up, and the corpora expands like balloons. And once the blood goes into the penis stays hard because the blood has flowed in, but it's not flowing out. And so this is actually something that's unique, a kind of a special ability that the penis has, because most of the time when blood enters into tissue, it drops off oxygen, it picks up waste, and then it circulates out.
Right.
But it doesn't do this in the penis. It stays in the penis unless it's impeded by some kind of physical abnormality or some kind of psychological inhibition.
Which is where we're talking about erectile dysfunction, where blood is either not going in or not staying. And
exactly.
Right, to simplify this. Yeah. Okay.
Yeah, absolutely. And so when ejaculation occurs or when arousal is interrupted, right? So a man starts to get nervous, or like their kid's crying in the next room, or maybe the doorbell rings, then the result is what we call detumescence. And so detumescence is when the blood is released from the corpora, it flows back out, and then the penis becomes flaccid. And so those are kind of the mechanics.
So the only thing keeping the blood in there, in the penis, are these systems that are very tied to the brain. Well, no, I guess physically too, you said. There can be mechanical issues with this functioning as well.
Absolutely.
But very sensitive to what's happening in the brain to keep that electrical flow going, to keep the channels one way.
Absolutely. So it's such this complex interplay between all of the systems in the body. And so that if anything goes wrong with any of them, right, then there can be erectile dysfunction.
So I hope that the listeners, the people that are listening to this and are struggling at all with erections, I hope you appreciate how sensitive a system this is, how common a struggle is, and how it makes so much sense, right? It's not like people should be able to perform on demand and, keep it up. And, it's so much more nuanced than that. So anyway, I hope people are taking heart listening to this. Like, of course I struggle.
Of course. Yeah. Not everything's going to work 100% every time.
Right.
So, yeah.
Right. Okay. All right. So you talked about some of the physical causes of erectile dysfunction. Is there anything else you wanted to say about that besides medical conditions? Did we cover all?
No, I think I kind of gave an overview of most of the most common ones that we see. I mean, there's so many, but those are kind of some of the, so like I said, so blood flow, and like you were saying earlier, not enough blood into the penis, or blood not being able to stay in the penis, and then hormonal and neurological. I guess I do want to say one thing around medications, because
Okay.
I think that would be helpful. So it's estimated that 25% of erectile dysfunction is the side effects from different medications.
Okay.
And so the most common types of medications that are linked to erectile dysfunction, we're looking at antidepressants,
Right.
anti-ulcer drugs, tranquilizers, and diuretics. And the most common type of drug that may lead to erectile dysfunction is blood pressure medications.
Right, because that's a diuretic, right?
Yeah. And so men with erectile dysfunction are 38% more likely to have high blood pressure than those without. So many are taking these medications, which further cause problems.
And, just a reminder here, don't go off your meds because of this. If you're having side effects, the medical treatment is important for a reason. So make sure you're consulting with the physician if you're going to look to make any changes or see if there are alternatives or something.
Exactly.
So, and I guess the other thing I'd put in the physical cause is insufficient stimulation.
Yeah.
So, because I think, I see clients who think, just the thought of sex should be enough to give me an erection, but that's not necessarily, maybe that's true when you're 16 or something, but it's not always true. And I think people are uninformed sometimes about how men need attention and stimulation too. And so I would put that as a physical cause. Are they getting enough stimulation to be aroused physically? So, okay. Hi, it's Jessa here, taking just a quick break. Thanks for listening so far. I wanted to let you know about the sex quiz that I've put together called How Healthy is Your Sex Life? I've taken a close look at the typical ways that I see couples get into trouble with sex, including avoidance, neglect, negativity, distraction, and boredom. And the free quiz will score your individual results based on these factors. And then I provide my recommendations and ideas, including my top 10 sex tips, which will help you make instant improvement. If you'd like to take the quiz and see how healthy your sex life is, you can do it right now at sexhealthquiz.com. So what about psychological causes?
Yeah, so psychological causes. So as sex therapists, obviously, we understand that erectile dysfunction is multidimensional, right? So there's this interaction between physical and cognitive and behavioral and emotional and identity and intergenerational and also relational. Right. And so I guess I'll talk a little bit about some of the immediate causes. So this is what is happening in the moment versus kind of remote causes, which are those that have developed over time. And so we know that what's happening in the present moment can impact a man's ability to get an erection. Right. And so you need two really basic things for an erection. So one would be arousal and the second is relaxation. Okay. And so anything that disrupts either of these in the moment can prevent you from getting an erection. So this is where we're looking at performance anxiety. We're also looking at one's overall psychological state. So is there depression? Is there anxiety? Are there other things going on? Right. We're looking at being in an uncomfortable or unsafe environment. We're also looking at how well are you getting along with your partner? Yes. A big one. Right. So we already touched on performance anxiety a little bit. So that's, I would say, the number one thing that I see in my office in terms of difficulties with erections. And an individual often becomes anxious when they're kind of tracking their partner more than they are themselves. Yeah, I talk about that with people all the time. Yeah. So this mind reading, right? And instead of tuning in to kind of one's own pleasure and sensations, really getting trapped up in the brain around, what if I lose my erection? Or what if my partner doesn't think I'm sexually skilled? Or what will my partner be disappointed in me? And so when an individual is anxious, what it does is it disrupts the brain's ability to send signals or messages to the penis to allow for that extra blood flow. Okay. So another big one is the relationship factors. Right. And so those are things like level of attraction, communication patterns, conflict resolution skills, feelings of safety and trust, one's capacity for intimacy, partner's sexual problems or health status. And so the approach to erectile dysfunction historically has been focused on just the man, but I really think that there is often, almost always, a relational component as well.
Yeah, I totally agree with you. That's why I work almost exclusively with couples. And no matter what their sexual problem is, they tend to think the person with the symptoms is the patient or something, but it's like, no. The relationship affects sex, sex affects the relationship. You have to work on this as a team.
Absolutely.
Yeah.
So those are kind of some of the things that are happening kind of in the moment. And then we have these remote causes. So these are things that have kind of developed over time. And so for these, we're looking at things like, it's how our past experience kind of contributes to the erectile dysfunction. So for this, we're looking at like a history of trauma, particularly sexual trauma. We're also looking at religious and cultural messaging, and also family messaging around sex and sexuality.
Yeah. And then you were talking about, you used the word identity not that long ago too. So I think, that also seems like one of those remote causes about what is it to be a man, or, I mean, certainly people might even struggle with something like gender identity or something like that. But I'm just thinking all the identity issues that we bring into it and the questions that we might have, or the self-consciousness or whatever other struggle we might have is going to impact, an ability to be aroused and relaxed in each encounter too.
Absolutely.
Yeah.
Yes.
All right. So let's get to maybe the more positive aspect of this in terms of treatment, treatment and I guess just approaches. Like, how do you maybe accommodate some of this too, right? Some of it's going to be resolvable, some not. So what are the recommendations for people that are struggling, right? What are, I guess let's start with the medical or physical treatments and then go on to the psychological.
Yeah, so I think there's a number of factors to consider when we're thinking about treatment. We're looking at what is the level of severity, what is the cause of the dysfunction, what are some safety and risk factors, what is the relationship like with your partner, where are your financial resources, and then also what is your level of comfort with the treatment. And just as you kind of said, hey, don't stop taking medications without talking to your doctor. I mean, I really think and kind of want to express the importance of working with a physician, talking to them about the different options that are available, and not just going rogue and kind of ordering things online. This is commonly what I see my clients doing.
Right.
There's a lot of online pharmacies where you can just order whatever you want. But I think, most of these treatments are relatively safe if used under the care of a physician. But I think once you kind of start ordering things and doing things yourself, they can be really harmful. So I think I kind of wanted to put that disclaimer out first.
I appreciate that.
So I'll do kind of a quick overview of some of the medications, devices, and also implants that kind of can help with erection. And so the first category, first line medical treatment for erectile dysfunction, as we all know, are these PDE5 inhibitors. So this is your Viagra, Cialis, Levitra. I think the origin story of these medications are really interesting. Has anyone shared that on your podcast
No,
yet?
They haven't. I mean, I remember, learning it in my sex therapy training, but no, it has not been shared on the podcast. So yes, please do tell. Where did it come from?
Okay, so these medications were discovered in the late 90s. They were just discovered by chance. They were first developed as a vasodilator for the treatment of hypertension and coronary artery disease. And so in clinical studies, the drugs were not found to be very effective for these purposes. And so then the manufacturer asked for these men to return the drugs, and few of them did. And when they asked why, these men said, we are able to obtain these firm erections that many of us, remember from our youth. So this is kind of where they
and especially
came on board.
If you're talking about people with hypertension and heart disease, we're more prone to erectile dysfunction in the first place. And they're like, we're not giving this back, right? We're loving this stuff.
Absolutely. Absolutely. I'm hanging on to this.
Yeah.
So the main chemical at work for PDE5 inhibitors is a PDE5 inhibitor, boosts this enzyme that relaxes the smooth muscle cells inside the penis. And then sexual excitement and arousal combined with the drug enables the arteries in the penis to widen and for the spaces in the erectile chambers to fill with blood. They're very, very effective. And so, like I said before, 70% of men who have some kind of physical cause They can help, and for those who have a psychological cause, effective in 85% of these men. So this is why we see a lot of people using them.
Right.
But I do think it's important to point out that, these drugs do not stimulate libido or desire.
Yeah.
And they don't work, right, if there's no sexual excitement or arousal. So if a man
it's not like take a pill and get an erection, right?
Yeah,
it just helps you.
Exactly.
It helps you develop and keep an erection that you would get from arousal, right?
Absolutely.
Yeah. And all three of those medications work slightly different, right? Like if one doesn't work for you, it's worth trying the other ones, right?
Yeah. Some are longer lasting. Some fatty foods can inhibit. So definitely.
Okay.
They can be. And then because they all work a little differently too, the side effects can look differently. So if you're having side effects with one, you might not have them as much with the other. And the side effects are pretty well tolerated. So like headache, facial flushing, maybe an upset stomach, nasal congestion, muscle aches. Most of the men that I work with find them tolerable. A few of them have stopped taking the medications because of the side effects.
Yeah. Okay. But I love how you point out it doesn't give you libido and it does not fix the dynamics around sex that you might be having with your partner. So just because you can get an erection right now doesn't mean your partner necessarily wants to have sex. Like there still could be a lot of stuff to work out in potentially a sex therapist's office.
Absolutely.
Yeah.
Absolutely. So there's also vacuum constriction devices. And so this is a tube that you place over the penis. You activate a pump. It creates this negative pressure, draws blood into the corpus cavernosa, produces an erection. And then once the penis is engorged, you use this constriction band placed over the shaft of the penis. And then you remove the tube. And so this is really great for men who have spinal cord injuries or diabetes or arterial insufficiency. They also can be really helpful for men who have a psychological origin for their erectile dysfunction. The use of these are incredibly safe, about 95% success rate. So they're men find that they're very successful. But for most men, the satisfaction with treatment tends to wane over time. They're cumbersome, they're inconvenient, they can be kind of unnatural. And also, I think what is important to point out about these is that the erectile state that's produced from the vacuum constriction device is different from a normal erection.
Oh, okay.
And so the skin temperature is lower. So it's actually, your penis can be quite cold because of that restriction in blood. And then also, the veins of the penis can be distended, and then the penis may buckle or pivot at the base. So that can require some stabilization during intercourse. So some men and some of their partners don't particularly enjoy kind of the erection that comes from these.
Oh, okay. I had not heard that before. That's really good information. I certainly have had a few male clients that did not enjoy using a pump. It just felt way too mechanical, basically, and so separate from a sexual encounter.
Right.
It's like, well, do I go do this first? And that, and you're creating erection without, largely without any arousal yet in the mind. So you're creating this, what they told me is you're creating this mechanical thing, but they're not in a sexual place in their mind yet. So that was a tough thing to straddle.
Yeah, I don't have many clients who use these.
Yeah.
The constriction device or the tourniquet can be used alone without the aid of the vacuum device. And so that you just put this adjustable loop at the base of the penis, enhances erection by retaining the blood flow. And then it can just be removed after completion of the sexual activity. So I find that men do use those on occasion.
Right. Okay. And then what's the sort of the next step up? So
then we're looking at injection therapy. So this basically involves injecting a vasodilator or a combination of vasodilators directly into the shaft of the penis. The medications are more powerful than PDE5 inhibitors, like Viagra, because you're injecting them directly where you want them to work.
Yeah.
And in contrast to PDE5 inhibitors, no stimulation or desire is actually necessary for the erection to occur.
Okay, so this is just going to make one.
Yep. And efficacy is about 80%, so very effective. And they're particularly helpful. Injections are particularly helpful for men whose erectile difficulties are the result of diabetes or prostate surgery.
Okay. Oh, yeah. It was just occurring. I'm thinking about a client who's using this after prostate surgery, and we didn't mention that as one of the physical causes, but that's an important one to note.
Absolutely.
Okay.
Yes. Yeah. Okay. So those are the things we might try first.
Mm-hmm.
And then we're thinking about if those aren't working, then we're looking at third line medical treatment. And so these are the implants.
Okay.
And so there's two main types. There's malleable or inflatable. And so malleable are kind of the older version. And so these flexible rods are inserted into the erectile tissue of the penis. And after these rods are in place, the penis is actually always semi-erect, but will never be fully erect. And the penis just simply needs to be lifted or adjusted into an erect position in order to have penetrative sex.
Okay, I'm almost picturing, I can't quite come up with the name, but picturing a toy that you sort of bend and twist and reshape.
Yes, yes.
Okay, so that would take getting used to. Yeah.
Yeah, for sure. And so I think most men prefer kind of this newer version, this inflatable version. So these two inflatable cylinders are surgically inserted into the corpora cavernosa. It includes this pump, which has these fluid-filled kind of reservoirs that are implanted either in the scrotum or the lower abdomen. And then when an erection is desired, the man squeezes the pump and the fluid goes from the reservoir into the cylinders, which expand and swell, and then they make this kind of natural erection. Mm-hmm. And then when the man wants the erection to go down, then he just releases the release valve, and then the erection will go down. And so most men prefer this inflatable prosthesis because the penis looks kind of relatively normal, right?
Yeah.
Where the malleable one, it's always kind of semi-erect, and they are able to have a lot of control over their erection when they want it. The thing to know about the inflatable prosthesis is it does require kind of more extensive surgical procedure than the malleable device. It also has a higher rate of malfunction. I think the technology is getting a lot better, but we're looking at a life expectancy about 10 to 15 years. So depending on when you get it put in, you might have to get it removed and another one put in.
Okay, but that's possible yeah. I was wondering about the sort of maintenance about that, and do you need fluid change out of this closed system? Or I guess not, it's totally closed and it's fine.
Yeah, I believe so. It's a saline solution. But sometimes they do malfunction, and so there can be problems with that. But the satisfaction rate is really high with these, about 80 to 90%, but I've actually heard satisfaction even higher than that.
Okay. I think it's important to note that once you go for a surgical implant like that, any hope of a natural erection is gone. So this is that's why that's the sort of the last line of treatment, right? This is, I don't, drastic might be too strong a word, but really permanent.
Yeah, it permanently alters, and it makes it impossible, like you're saying, to have an erection naturally if in the future. Yeah. And then there's just some interesting things, like there's some stem cell research that's being done, and some doctors are starting to provide that stem cell treatments. And I think it's still being researched. I think there's a lot of things on the horizon as well, but those are some of the major ones we're looking at. And if you were to go meet with a urologist and talk more extensively about different treatments, these are kind of the major ones that they would probably talk with you about. Yeah.
All right. So we don't have a ton of time left, but let's try to cover the psychological treatment, like what's happening in our offices as opposed to the physician's office.
Yeah. So, we're working on, helping men kind of regain their confidence with their erections and enhancing intimacy and pleasure and arousal and desire. And we're doing these through, anxiety reduction, through mindfulness techniques. We also might be using some acceptance and commitment therapy. We're also doing, like you were talking about, systemic or couples work, using some cognitive behavioral therapy components, and then also just a sexual education. I find I do a lot of educating in my office as well. Yeah.
I know that I certainly try to take the focus off of erections. Like, what's the breadth of sexual experience a couple can share, and can they relax and just enjoy that and take the pressure off of this performance? At least in terms of talking about the anxiety part of this or the psychological stress, that goes a long way. And then, like you said, too,
Yeah,
on your own experience, the ability to just sort of pay attention to yourself and let it feel good and don't worry so much about your partner,
Absolutely. And I think that it's such a relief when men find out that they can focus on their own experience, and it doesn't always have to be penis and vagina intercourse, and that there are these other options available. It's like they didn't know that was possible or that existed.
Yeah, or that's okay somehow. And, and I have to say, sometimes I need to do, well, I wouldn't say convincing, but the partner is not always eager to let that go, right? Like sometimes there's a little bit of buy-in that has to happen with both people to be willing to take the pressure off of like intercourse for now and enjoy the rest so that the pressure can come down and hopefully they regain that, capability together.
Absolutely.
Yeah.
Yeah.
Anything we missed, do you think? I mean, I feel like this was a pretty comprehensive discussion.
No, I can't think of anything unless you want me to go into detail about any of the psychological treatments, but I don't think we missed anything.
Yeah.
I mean, I'm sure we missed a lot, but
right. In some ways it's just the beginning, but at least it starts the conversation. So where can people learn a little bit more about you? You've got a website or any projects you want to share that, certainly I'll link in the show notes too.
Yeah, I mean, they can just find me at my website, www.drpomeranz.com. So I have a brick and mortar therapy and consulting practice in Silicon Valley. And then I also offer teletherapy serving all of California and also Massachusetts.
Oh, okay. That's good to know. So licensed in 2 places. So wonderful. I will share all of that. And I look forward to hearing from people about how helpful this has been. So thank you so much for taking the time.
Yeah, of course. Thank you so much.
You've been listening to Better Sex. Please visit our website, bettersexpodcast.com, for show notes and additional episodes.
And that's a wrap for today. I really hope you enjoyed the episode. If you are enjoying the podcast, if some of this material resonates with you and you would like to make a difference and make sure that this keeps coming out in the world once a week, ongoing, there are a couple things you could do to show your appreciation. The first would be to go to iTunes and rate and review the show. That really helps us be found by new listeners when you review the show on iTunes. You can find a link at bettersexpodcast.com/iTunes. The other thing I want to invite you to consider is becoming a Patreon. For a small monthly pledge, you get some benefits. So for $2 a month, you get advance access to every single episode. For $5 a month, you get a chapter of my upcoming new book. And for $10 a month, I host quarterly get to know you and question and answer chats over the web, and you get invited to that. I would love to have your membership in that, become part of the Better Sex family. You can find a link at bettersexpodcast.com/Patreon, which is Patreon. Again, thanks for listening. I'm glad you're here. Feel free to comment, ask questions, get in touch. I'd love to hear from listeners. Thanks.